On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with Dr. Paul Douglas from Atlanta, Georgia, and we're talking about some of the exciting new information that's coming available here at ACC.13 in San Francisco. So, Paul, some new information, some old information, some drugs, some information about ranolazine, a drug we've had around for a while.
Absolutely, and it's really exciting, I think, that we're seeing new indications for old drugs. We're looking at different patient populations, and the ranolazine trial looked at patients with chronic stable angina who were being treated for angina and looked at the frequency of their anginal episodes and the use of nitroglycerin. And what they were able to show is that you could reduce the number of times that patients had angina, and you could also reduce the amount of nitroglycerin that they were using to treat their symptoms. And that's not new news. That's old news. We know that the drug's effective. But what we didn't know is that there was a suggestion that maybe in patients who have chronic diabetes, type 2 diabetes, the hemoglobin A1C may go down, and it hopefully may be helpful in that particular high-risk cardiovascular population.
Yeah, it's interesting to think that this hypoglycemic effect of ranolazine may have some value for anti-angina as well. Of course, exactly. The changes were very small, one anginal episode a week or even longer, and some people might take issue with the fact that chest pain and nitroglycerin use is a little bit subjective, and in fact there's a big placebo reactor component for that. There wasn't ST segment changes with exercise or anything, but nevertheless some good data from electronic diaries.
No, I think you're absolutely right. We'll need more studies with harder endpoints to really see if this really makes a difference. But I think we shouldn't lose sight of the fact that controlling patients' symptoms is important. And if we can do something to lower their hemoglobin A1C, that can't be bad.
Yeah, symptoms are the most important thing.
Exactly.
Really. That's what our patients want.
Exactly.
Now, from the standpoint of new drugs, inclacumab, which is a P-selectin inhibitor, P-selectin being an endothelial cell receptor that slows down the white blood cells and platelets and gets them to be more resident along the endothelium, probably adversely so in PCI, and so this SELECT-PCI ACS study looked at the value of an inhibitor of P-selectin.
Absolutely. Inclacumab, that's a interesting compound. Now we have a new target. We've always identified the platelet as the enemy. So those of us who do interventions know that you really want to turn those platelets off. And so now we've identified another thing that we can antagonize. And it appears that it really makes a difference. And so the concern that I have, though, looking at this new trial is the safety issue. And that is this drug safe to use, and is this something that we may be able to incorporate into our clinical practice that will reduce the troponin rise that we see post-PCI, because we know that increases your risk going forward after the procedure. So anything that lowers the troponin should be good, but there may be a trade-off in terms of safety with this.
Interesting that troponin was the endpoint, but we know if troponin goes up after a PCI, that's got adverse prognostic significance. In addition, as you point out, even though none of the serious adverse effects like myocardial infarction or death were significantly different between the treated group and the placebo, if you put them in aggregate, it's something that's going to bear a lot of watching in the future as to whether this can be done. And the last somewhat interesting thing about this study was that the p-values were all around 0.5 something, 0.06, and so
right.
they were right there at the hairy edge, but not necessarily under that 0.05 that we usually look for.
Absolutely. And so I think we're going to need a larger trial that has more power so that we can really see if this is signaling a improved benefit for our patients. We'll have to see. But it's an early, exciting target, I think, that we've identified. And hopefully, that it's going to bear fruit for us.
Boy, I think you're right. We've been working so hard at the platelet for so long that it's good to have a new target, and hopefully one we'll be able to exploit. So lots of good information at ACC.13 here in San Francisco. More to come tomorrow and Monday.